Well, good afternoon, everyone. Welcome back to our exam for webinars for the 2022 ABOG Oral Board Examinations. Today is our makeup webinar from this past Sunday, where we apparently had a conflict with our course that we were running. Happy to have all of you here this afternoon. We are doing case list defense. Thank you to all of you who have joined us, and we will get right on to our case list here. So I can get that out of the way. Okay, if everybody's case list up for October, we are going for an hour and a half today, I believe, until 2:30 Eastern, and I'll be happy to talk with any of you about anything you'd like to practice for your case list. Do click the raise your hand button, and we will just go through in order. Dr. Mariah, thank you for getting right on there. I'll be with you in just a second. As soon as I grab your case list here for a moment. Gita, coming to you in just a second. Wait for you for a moment to unmute, and while we're waiting for that, I'll bring your case list up here. Okay, here we go. Let's see, Gita, if you can unmute yourself. I think I've got you set. There we go. Can you hear us okay?
I can, yes.
All right, oh, good. Thanks for joining us. All right, first up, what would you like to talk about? We have your entire case list here. Be happy to go anywhere you would like.
Maybe the office list.
Sure, office. Is there anything at the moment you're looking at on office that you'd be interested in us looking at, or we can pick something completely at random?
Random is fine.
Okay, let's see. Alrighty. Let's see. Find something maybe we haven't talked about in the past week or so. Let's see. Great. Quick pick. Let's see. Case number 14, maybe. We don't get too much on peds gynecology, if that's okay. So it looks like a 13-year-old dysmenorrhea and suspected endometriosis. So could you tell me a little about the examiners would probably say in a 13-year-old who comes in with dysmenorrhea, what would be a basic differential diagnosis? And then they're sort of interested in seeing where endometriosis falls, I think, within that.
Sure. So with dysmenorrhea, so this patient specifically had cyclical pelvic pain at the time of her menses. With that symptom, my differential can include gynecologic and non-gynecologic etiologies. So from a GYN perspective, endometriosis was at the top of the differential. There could be structural concerns. So for example, vaginal septum or imperforate hymen. There could be an ovarian cyst. And if this was mid-cycle pain, it could be Mittelschmerz pain or ovulatory pain. There could be non-gynecologic concerns such as any GI issues, constipation. There could be concerns about the bladder, so UTI. Foreign body also could be a consideration.
Sure. Yeah. Anything else that might be important to consider here? We have a good list so far, I think.
Pregnancy. I mean, she's young and not sexually active.
Yes, of course. Yeah.
That would be a consideration.
Okay. Any other sort of category of disorders that might be important to consider here?
So musculoskeletal and neurogenic conditions.
Anything gynecologic?
Trying to think of what else I'm missing here. We talked about structural.
Yeah.
I can't think of anything off the top of my head.
You're thinking in general of something otherwise inflammatory, I'm assuming.
Yes, PID, I guess, would also be a consideration.
Again, infections might be, that might be some important. And I think if you're discussing this case in the exam, very early on, I'd want to get to one of the first questions you want to know is this sort of primary or secondary dysmenorrhea? Because there's a different differential diagnosis if it started from her very first menstrual period as opposed to whether it's at recent onset at age 13.
Sure. For this patient, she had recently began menstruating, so the symptoms started shortly after she began menstruating.
Okay. This is just sort of, I think, an advice, and it doesn't have to come up unless the examiner sort of brought it, or they keep saying anything else. But just because among ACOG publications, and we're sort of all these days, we're sort of talking about the idea of trauma-informed care and sort of how to help and work with, as non-psychiatric trauma specialists, primary care providers and gynecologists who may work with women, young women or older women who have experienced emotional, physical, or sexual trauma. We do want to consider that some of the physical manifestations in a patient who has experienced trauma could be like this. And I might just sort of keep that off there and drop that into the conversation if we felt we
Okay.
wanted to at one point. And a 13-year-old, an adolescent with symptoms that are they're potentially really limiting or disabling, that would be a consideration. So next question I think would be, so you're considering endometriosis. If this patient truly had already at the age of 13 developed endometriosis, what constellation of symptoms would you expect to find on a history?
Yep. So with these patients, I have them do a menstrual diary. So this patient described pelvic pain at the onset of her menses that lasted during the duration of her menses, and then this pain tended to dissipate at the time that her menstrual cycle stopped.
Okay. Would that be a characteristic pain pattern for endometriosis?
That is, yes, that is typically how endometriosis presents.
Okay. So would you would you expect to find anything on physical examination if you were trying to suss out whether this might actually be endometriosis?
If the patient had an endometrioma or endometriosis in an ovary, sometimes that can present with an enlarged mass on a pelvic exam. Otherwise, on exam, sometimes there can be pelvic pain and deep palpation of a pelvic exam, but otherwise there may not necessarily be any physical exam findings.
Okay. So in addition to history and physical exam, to investigate this potential diagnosis, is there any particular testing that you would consider or order?
So I would want to rule out pregnancy.
Yes, of course. Okay.
And then as far as any additional laboratory work, I wouldn't necessarily do anything else. I would consider a pelvic ultrasound. However, this patient's physical exam was not concerning, so I didn't proceed with an ultrasound.
So how might you establish a diagnosis of endometriosis in a patient like this?
So the only way to truly know if there is endometriosis is with laparoscopy and a pathologic diagnosis by taking a peritoneal biopsy. But in somebody who's newly presenting, I discussed medication management as a first line to see if this would treat her symptoms.
Okay. So in a patient like this, what would be your criteria then for potentially recommending to her a laparoscopy?
So if she has failed first line medical management with NSAIDs and continuous oral contraceptive pills, I would await at least 6 months of therapy. And if she's failed that, then I would recommend a diagnostic laparoscopy.
Okay. Any other criteria for recommending a laparoscopy?
If she had a endometrioma or clear or like stage 4 endometriosis, I guess, well, that would be diagnosed on laparoscopy. But if there was a sign of a pelvic mass, then I would recommend a laparoscopy.
Sounds good. If you were to perform a laparoscopy, can you sort of walk me through your steps of what would your laparoscopic evaluation and procedure consist of?
Sure. So upon entry of the abdomen, I would do a thorough evaluation of the pelvis. So I'd, have the patient in Trendelenburg position. I would do a detailed evaluation of the peritoneum. I would look at the adnexa. I would look at the uterosacral ligaments. I would look at the bladder serosa as well to look for any endometriosis implants, which can vary in their color and consistency, anywhere from clear lesions to the classic powder burn lesions.
If you identified endometriotic lesions, how would you manage that?
So if I identified a lesion in an area that was safe to remove, meaning in an area that did not have any important pelvic structures such as the ureter, bladder, or any major vasculature, then I would remove a portion of the peritoneum to send to pathology for confirmatory diagnosis.
Okay. Yeah, I'm assuming you're meaning a portion of the peritoneum with lesions on it.
Correct. Yep.
Okay. Would your surgical management involve anything else at this point?
If I saw several lesions, I would also fulgurate them using electrocautery, assuming they're in a safe location.
Sounds good. Okay. If your laparoscopic examination was completely negative in all respects, what might your continued evaluation and management of this patient consist of?
So then I would counsel this patient that her pain may not necessarily be due to endometriosis, and it may be due to some of the other issues that were discussed before that are non-gynecologic in origin. It could be also due to pelvic floor dysfunction, GI in origin. So at this point, I would consider involvement of pelvic floor physical therapy and potentially evaluation by GI as well.
Okay. Um, is if you've had a negative laparoscopy, does that mean that definitely that she does not have pelvic endometriosis?
No, it doesn't. It just may not have been visualized grossly at the time. Sometimes it can be easy to miss like clear implants that
Okay.
are a little bit harder to
Yeah.
visualize.
So in light of that, so far, I think this will be our last question. You've used combination oral contraceptives and you've used NSAIDs. Uh,
Mhm.
what other, if any, medical managements might you then consider to try to manage her symptoms from a gynecologic perspective if you were still working through her evaluation?
Is this assuming that she has a diagnosis of endometriosis or not
No, no,
necessarily?
we had a negative laparoscopy. We're still working through it, but she is still having cyclic recurrent symptoms, which are limiting her.
So I would involve pelvic floor physical therapy with the consideration that there may be some pelvic floor dysfunction at this
Okay.
point. There has been shown to be underlying association with depressive and anxiety symptoms as well. So I could discuss an SSRI with this patient as well.
As far as trying to manage though her cyclic pain symptoms, is there any other medication management that you would feel comfortable or would consider offering to her or discussing with her?
And as an alternative to OCPs, there are several other hormonal options to consider if OCPs are not working, even though that is generally the first line. There are some newer agents that I'm not as familiar with, but could consider, I'm forgetting the name now, unfortunately.
It's okay.
But there are some newer agents that can be considered for the treatment of suspected endometriosis as well that can be used for a limited time period.
Okay.
Um,
Are
and
there any
then
other established or kind of long-standing agents that you might consider using?
Long-standing agents for the treatment of cyclical pelvic pain. I can't think of anything at this time.
Okay. Um, so if she's still having persistent and sort of limiting symptoms, your plan is to send her to other providers or to maybe look into one of the medications that you're not sure about and discuss that with her?
Correct.
Okay, all right, we can work with that. In the exam, I think you could also just talk about anything that's sort of progesterone based, which might provide long-term suppression at her age. Certainly, a brief trial
Yeah.
of maybe a Depo-Provera would be reasonable. A levonorgestrel implant, you could, IUDs, you can be used in young adolescents if you like to. These are all things that sort of have a long-term progestational effect that might actually be more effective than low-dose continuous OCPs. And I think any of them might be reasonable as well. If you're thinking about a Lagalex or Orion, any of these other kind of neuro
Mhm.
medications, so it'd be reasonable as well. But I think in the exam, I might start with sort of the really well-established ones and kind of work down the list. But I think you could mention any of those, and the examiners would absolutely accept it because
Okay.
there are people working in adolescent gynecology are using these things all the time.
Sure.
You got to be reasonable. Good. Gina, thank you. We kind of went through that and got into some deep detail. That was actually a really nice description. It's perfectly okay in the exam if you're sort of missing sort of the names of certain medications or things like this. This is something at which you can go and look it up. The patient's, health is not an immediate risk if you have to, call her back tomorrow and do something like that. The examiners will absolutely accept that. What was
Okay.
really important in your case discussion is you had a reasonable diagnosis. I mean, 13 is kind of young for endometriosis, but we could consider it. You had an idea of history and physical exam. You had very specific and appropriate criteria for when we would think about a surgical procedure in a young adolescent, and the bar was set appropriately for that, and how you would manage that as well. Nice examination and biopsy-proven endometriosis if possible. And the examiners will very commonly they will give you the scenario of a negative laparoscopy to sort of see where you will go,
Okay.
realizing that a lot of us are just sort of thinking the laparoscopy is going to solve everything, and we have to have a plan if it doesn't. And you actually described an ongoing plan, which is reasonable, and it involving some other people as well as some things that you can do by yourself. And that's a really tight, high-level pass on the examination, I would say. Nicely done.
Perfect. Thank you.
Going through that with us. That was great. Thanks. Let's move on ahead here. Let's see. Anyone else, please do raise your hand. Janelle, thank you. Dr. Santos will come to you in just a second. And Dr. Beetham will move right along here. Just a second here. Thank you. All right. Let's see. Janelle, I'll come to you. Christina, I'll come to you right after that. Janelle, I'm going to go get your case list for just a second while we're getting you unmuted. Sitting right here. Great. Let's see. Janelle, just unmute yourself when you have a moment. It sometimes takes a minute to transfer over. There you go. I think we got you. Can you hear us okay?
Yeah.
Yeah. Oh, good. Great. Ready to go. Any particular part of your case list that you'd like to look at?
I think you're in Beetham's case list.
Oh, wait. Well, I'm sorry. I'm sorry. Let me get you, and then we'll come to Dr. Beetham. That's what. Hang on. Just all the way down here. There you are. All right. Now we're good. Sorry about that. All right. We're good to go.
Yeah, and I'm an MFM fellow, so any gyne or office would be.
Okay, let's see. Maybe do guidance since we just did office, if that's okay. Let's do something on that. Great. Let's see here. Let's kind of cruise down, maybe find something that we haven't done before or recently. Let's see. Great. Can we do case number 7, laparoscopic sterilization? I'm trying to pick stuff here that these things can come up in the exam because the examiners like to present unfamiliar scenarios. And they also, most of us think of our suction DNCs and our sterilizations as kind of throwaway cases because there's not much to talk about aside from sort of counseling and management. But it's surprising where the examiners can go with this. So in this case, I think where we might go is this is a laparoscopic bilateral self-injectomy. So the scenario hypothetically would be you've put in your laparoscope and you are looking around and you're getting ready to do the self-injectomy. You're going to start on the right side of the pelvis, but you notice that over by the left pelvic sidewall, there seems to be a retroperitoneal hematoma. And there is a very small amount of punctate bleeding coming from below the IFP on the right-hand side. What might possibly have caused something like this to happen as you're beginning of what was supposed to be a very uncomplicated laparoscopic sterilization procedure?
Yeah, so if I notice that at the very beginning of my case, then I have to wonder if my port placement caused that retroperitoneal hematoma.
Okay.
Yeah.
So what would your initial evaluation of this consist of? And in the exam, when they present a sort of unexpected scenario where the acuity level has suddenly gone up, I would just talk about what you were going to do in the first 1 minute, maybe, and then we'll go on from there.
Okay. So firstly, I would just watch the hematoma to see if it's expanding, to see if there's any active bleeding in the pelvis, and I would let my anesthesia team know what's going on and just keep track of her vitals and be kind of sensitive to any vital sign changes.
Good. So you said whether the hematoma expand, and you said whether there's any bleeding in the pelvis. What particularly are you thinking of, and where and how would you look for that?
Yeah. So what I'm thinking of is oh my gosh, now I'm blanking on the vessel that the lateral port sites.
Well, we don't have to name the vessel, but it's somewhere around it's in the pelvic sidewall. It's near the adnexal. It's near the IFP. That could be any one of a number of things.
Yeah, so I'm thinking of vessels that within the abdominal wall that I could have hit.
Good.
Placed in my
Got
port.
it. Understand. Good.
Yeah.
So you're looking at where it is, and you're trying to sort out the local anatomy. You're looking for whether there's significant bleeding, and looking for whether the hematoma is expanding. Is there anything else that we should consider or evaluate at this point, just initially? And also, in notifying everybody in the OR and sort of planning for additional interventions is important as well. Go ahead.
I can't think of too much else. I mean, the way you're describing it, you said it's yeah, lateral pelvic wall. I mean, at this point, I think I would just look for my ureters, make
Good,
sure that
that's good.
uretered, but it sounds like I'm likely far away from those.
Okay. So you said it could be from your port placement. Could anything else have happened here as you are getting here? Do you put a bit aside from your ports? Do you insert anything else into the abdominal cavity as you're establishing abdominal wall entry when you do these things?
Typically, my preferred method of entry is to do a varus needle entry. So
Got
it
it. Got it. Good. So does that bring to mind anything else we might want to consider and evaluate for at this point?
So yeah, if I'm concerned that I had an injury upon entry, then I'm also concerned that I could have caused a bowel injury.
Exactly. Good. Yes, exactly. So we just need to think about there might be some other intraperitoneal injury. And in the pelvis, it's going to be, small bowel, large bowel, or something in the retroperitoneum. Good. So let's getting back to the focal question here. If this appears to be a hematoma that is maybe about 4 centimeters in diameter, and it might be slowly expanding, what would you do at this point?
Yeah, so if the hematoma is expanding, then I think we would have to go looking for the source of the bleeding and try to ligate that bleeding. So I'm not as experienced with opening up the pelvic sidewall, so I would try to pull back up if I could, if someone's available. But
Let's do
if,
back up. Yeah.
huh?
Okay. I think calling back up is a good idea too. What type of vascular injury are we thinking of here? Are we thinking arterial injury, venous injury? Do we have a basic category for this? Probably.
Likely venous injury.
Venous. Yes, veins are very thin walled. They're much easier to injure. So, if this is a venous injury, what likely is sort of the intravascular pressure in that vein that is sort of bleeding into the pelvic sidewall? Just roughly.
Low.
Low. Yes, very low. Yes. Yeah. Would it be, do you think, more than, equal to, or less than the pressure of your pneumoperitoneum, assuming that we set our pneumo at about 12 to 15 millimeters of mercury pressure?
I mean, if it's bleeding, then it must be higher, right? Or else it would be.
Not necessarily. That's a little bit tricky there, but it could be actually lower pressure. It's just the pressure on the pelvic sidewall in millimeters of mercury is not the same thing as pressure per square inch of area. So we can have a pneumoperitoneum of 15 millimeters of mercury, and you can have a vein that has a 7 or 8 millimeter mercury pressure within it, and you can bleed into the pelvic sidewall because there is pressure within the vein, and there's a potential space in the retroperitoneum. So it could be bleeding. And you don't have to answer the question that technically, but I would say it could be low. It could be lower than your pneumo, and it could still be bleeding because apparently it is. But I agree with you that it's a vein. Arterial is fairly. Arterial would be a rapidly expanding hematoma. It would be immediately obvious, and those are managed quite differently. So venous is the easy one to talk about. So let's do that. Do you have to open the pelvic sidewall to take care of this? Is that necessary in this case?
I think I would, just because there are a lot of vital structures within the pelvic sidewall, so I wouldn't want to.
Yeah. So if you then size the pelvic sidewall and go in there, what's it going to look like in there? What structures are you going to look for, and how are you going to find them?
Yeah. So, this is tough.
Yeah. If you open the hematoma, what are you going to find when you look in there?
Yeah. So I would find branches of the internal iliac.
Really? Okay. You might. Are you actually going to find those? You're opening a hematoma, which means you're opening sort of a collection of blood that's in the retroperitoneal space.
Yeah.
Are you going to be able to identify specific structures easily?
No.
No, you are absolutely not. No. Are you going to be able to identify structures with any reliability that you could operate them without causing potential harm or further injury?
I mean, I
No.
would no.
No. So first cardinal rule here is we do not need to open these. And the examiners in the exam will often say, well, if the hematoma is expanding rapidly, what would you do? Now our answer is this could be an arterial vein, and we might have hit a branch of the iliac or something like that. Are we going to open the retroperitoneum in that case?
You would have
to. You have to think ahead to. But the question is, are you going to open it? And the question beyond that is, do you have vascular surgery privileges to sew up an arteriotomy without potentially causing more harm to the patient? I certainly don't.
Yeah.
So the answer to that question, and we'll go back to your question, is we can open the abdomen, we can put direct pressure on this thing for as long as you want to until someone with vascular privileges gets there, but we're having somebody else open it and identify it. It's not going to be us. And you can hold that thing for an hour if you need to. You can put on pressure there that's greater than systolic blood pressure of somebody who's under anesthesia. Not a problem. So the answer is, even in the arterial case, you will have to go in and operate on that, but it is not going to be us. We're GYN generalists. We need somebody who can operate on it. And that's not us. We would only cause harm. Let's go back. Our case is easier though. Low pressure venous hematoma. If you were to watch this thing over 15 to 20 minutes, what would you likely see happen to it?
Most likely it would stabilize.
Yes.
Yeah.
It would, because it is bleeding into a contained space, and there's back pressure. As you dissect this potential space of the retroperitoneum, there's back pressure, because remember that the area is the square of the diameter. So the resistance increases as the square of the radius or diameter of this size of this hematoma. So there's more and more and more back pressure on it, and that's a low pressure vessel. And you could put a unit of blood into the retroperitoneum. It is eventually going to reabsorb itself. Given the choice between opening it right now and watching it for a while, what would be your first choice?
My first choice would be just to watch it and see how.
That is the safe thing to do, and that's what we should do. Would you continue to do while you're waiting to do our sterilization procedure just to get that done? Is that reasonable?
That's a good question.
And that's different. I think your answer is going to be different from the question of, are you going to doing a laparoscopic hysterectomy? Are you going to start your laparoscopic hysterectomy while you're waiting?
Right.
That's a different answer. If you're doing just a bilateral self-injectomy, would you go ahead with the procedure, kind of, check in on it every few minutes, get your procedure done, and then maybe come back and look at it? Or should you just wait it out and manage this thing primarily right now?
I mean, I think it would be reasonable to, if I'm just going to wait, that's my strategy. I think it would be reasonable.
Yes, you're operating away from the pelvic sidewall. You're the fallopian tube. You're not going to incur any further problem in the pelvic sidewall by taking the fallopian tube off and moving them. So you could actually, while you're doing that, if it's stable or slowly expanding, get your procedure done to get that out of the way, and then come back and take a look at it if you'd like to. Yes. If it was 3 or 4, let's say maybe it's 4 centimeters when you first look at it, you complete your bilateral self-injectomy, you come back, 15 minutes later, look at it. It's now maybe 5 to 6 centimeters. What would you do at this point?
I would still continue to watch it. I mean, you do expect that it's going to enlarge, but that seems fairly slow, and I would.
Yes, it is.
Yeah. It would tamponade itself.
Yeah. This is blood that's collecting in a contained space, so eventually it's going to clot. How long would you normally expect for normal hemostatic mechanisms to take over for this thing to start to clot itself and organize itself?
Oh, that's a good question. I mean, it's fairly fast.
Yeah.
I mean, I want to say a minute or two, but I'm not sure.
Well, this goes back when we were in medical school, and we made a red top tube and figured out how long it takes blood to clot. If you sort of draw a tube of blood and wait for it to clot, how many minutes is the average for blood to clot in a glass tube?
I'm not sure. I want to guess like 5 to 7 minutes, but
it's supposed to be about 10 to 12. Okay. Is average or before. It can be 5 to 7. Some people clot quickly. If you're up to 12 to 15, it should really be clotted by then. So you're right. You can watch this thing. You don't even need to open the abdomen at the moment. You can just watch this thing, and you can sort of observe it, and it eventually will stabilize. If you continue to watch it and it stabilizes out at maybe a 6 to 7 centimeter hematoma, and you watch it for a while, and there's no continued enlargement on it, and your self-injectomy has otherwise gone well, what would your management be at this point?
Yeah, so if it has stabilized and I'm finished with the procedure, then I would just terminate the procedure at that point. Post-operatively, my plan would be to follow serial CBCs, just so their hemoglobin is stable.
Mm-hmm. Yeah. And would you, aside from doing laboratory testing, is there any other testing that you would consider?
No, I mean, I think just following her vital signs and her hemoglobin, following her abdominal exams too. Um, that's all I would do.
Okay. Would you consider any follow-up imaging on this patient?
No, as long as she's hemodynamically stable, no, I would.
Good. I think imaging is optional. I think that is fine. I agree, if you watch it and it's stabilized, the one question that we'll bring up, and we should do this just so we can be complete and let you go, is, so we talked about you have a pneumoperitoneum in there, and you've got a little of a bleeder in the retroperitoneum. To conclude this case, you have to evacuate your pneumoperitoneum. Are you concerned that lowering the intra-abdominal pressure is going to cause this thing to further enlarge?
Yeah, I am.
Mm,
No.
possibly. It
Okay.
might, but if you watch it for 30 minutes, I think we're well on our way to normal hemostatic mechanism taking over. And I think the answer might be it might or it might not. But I think it'd be okay to say it might. In that instance, sort of given that it might be sort of slowly enlarging because you have to take the gas out at some point. Would that in any way change your plan for continued care and follow-up with this patient?
If it might be slowly enlarging, I mean, I think it would just still be the same plan.
Sure. It's fine, and you can image or not image as you would like to. The examiners will finally ask you, well, would you consider having interventional radiology, do a study and try to embolize something here?
And that's a good question. I mean, no, I think if she's hemodynamically stable, everything's stable. Yes. I mean, there are risks to embolization, so
there
no.
Are. That is true. If it's handling itself, that is fine. If you've got something that really is expanding more rapidly, it's a difficult question because you can't take the patient out of the operating room to go to IR. So if in your hospital IR can come to you, it's an option, and otherwise it is not an option. And that's just sort of there's a little trick to the question when the examiners ask you that. But I agree. I think what we landed on here, and I think your conclusion on this is correct. These things are managed conservatively unless they are rapidly expanding, in which case that's an arterial injury. You need to open the patient, apply direct pressure. It's just basic ABCs of first aid, and call somebody in who can help to explore the retroperitoneum with you, but we should not be opening them. If it is a venous hematoma, the examiners are going to sort of press you and stress you to see if you would open it. But the general correct answer is no, not now. We can watch it. It can actually get big. I've actually been called in cases where there's probably more than a unit of blood in the retroperitoneum, but it eventually organizes itself. It's a contained space, and it reabsorbs. The issue with opening it is you now have bleeding into an uncontained space. So not only can you not go digging back in there without causing more bleeding, but now you don't have that back pressure and containment, and you actually can have significantly higher blood loss. And those are kind of the important points to consider when the examiners are kind of pushing you up against the wall in here. And in your defense, those are the things that I would bring up as to why it's potentially more hazardous to the patient to try to open these things.
Okay.
Good, Janelle, I think that was our most important discussion so far of the afternoon. Thank you for doing that with us. I think everybody who's listening in now, including yourself, if this comes up in the exam, I think we're going to be okay with that. Those are the important points. Thank you for gritting your teeth and going through that with us. Just to give you a chance, because that was a important discussion. Is there anything you'd like to ask about this, or kind of anything angle we didn't cover that maybe you'd like us to talk about for a minute or two more?
No, I think you covered everything, so thank you.
Yeah. Thank you. Thanks. We'll do something a little bit easier maybe for our next case. Let's see, Dr. Beetham, Christine, we're going to come to you just next. Grab your case list right here. Let's see, Christine, just take a minute to unmute yourself, and we are all ready for you. Hi, Christine.
All right.
Yours okay? Christine,
all right. Can you hear me?
Yeah.
Yes.
Okay. Excuse me. Yes. Hi. Okay. I'm ready for you. All right. We're going to go more mainstream now. Any particular part of your case list that you'd like to look at?
Nope. I'm whatever.
Okay, let's see. Can we do OB because we haven't hit that yet this afternoon?
Yes.
Since you're studying your cases, is there any particular topic or case on OB that you would like us to take a look at?
No, not necessarily.
Okay, sounds good. Let's see. We'll just pick something then. Can we do, so let's try to get some of the top 2 pages if we could. Let's see. Case number 4, maybe bacteremia due to E. coli pyelonephritis, 38 weeks, GBS positive. This looks like an antepartum remission, but we'll kind of carry it forward from here. It looks like, no, so actually she had, she eventually delivered and did fine. Good, great. So important question. A patient has pyelonephritis at 33 weeks of pregnancy. Can you give us a short list of what she is now at risk for the remainder of her pregnancy that maybe she wasn't at risk for before this came up?
So she would be at risk for recurrent pyelonephritis,
She would, yeah.
and at risk for urinary tract infections
Yes.
throughout the duration of the pregnancy, depending on if there was any precipitating factors that she had prior to developing pyelonephritis, then
Good.
those would still be present if there were
Yeah.
any sort of
Assuming this year of pregnancy was totally uncomplicated so far, what other things might we be concerned about because she's had pyelo at 33 weeks, beyond what you just mentioned?
So because she had pyelo, we may be concerned that perhaps if she had a stone, I'm trying to.
Okay. Sure. So urologic complications may be due to whatever caused the pyelo underlying. That's good. As far as obstetrical risk for the rest of the pregnancy, anything else we should consider here?
Oh, so she would be at risk for preterm delivery.
She would, yes, absolutely. You can use that for anything, absolutely. No matter what, she is at some increased risk of preterm delivery, either because this happened or because of the risk of it happening again or other complications. Anything else that's important that we should consider here that is a identified associated risk with pyelonephritis at any time in pregnancy?
So she could also be at risk for growth, I believe, growth restriction.
Yes, no, very good. That's what the examiner, yes, fetal growth restriction, exactly. That is an associated risk of pyelo. I suspect for her, maybe if it happened earlier in the pregnancy, but potentially at this point, yeah. So given that risk, in a patient like this, how do you assess at your office visits for potential fetal growth restriction?
So at our office, we work very closely with the maternal fetal medicine specialist. And so we would have the patient seen by them, and usually they would be performing serial growth scans about every 3 weeks.
Okay. So this is a patient though who's had pyelo, but we know again what I was asking is how do we assess for possible IUGR? So because she's had pyelo, are you saying that you would automatically put her onto serial growth scans?
For this patient, yes, we would. We did do that.
Oh, you did? Good, excellent, good. So she had it at 33 weeks. When did you get the first serial growth scan?
Well, the first growth scan would have been done when she first came in.
Very good.
To the hospital, and
Good.
then we would
Assuming that was normal, when would you do the next one?
2 to 3 weeks from that time.
2 to 3 weeks. Okay. The examiner is probably going to say, is it 2 weeks or 3 weeks?
3 weeks.
3 weeks sounds good. Good. At 3 weeks, what specific indices are you looking for on your ultrasound to identify whether we might be dealing with early growth restriction?
So we would be looking to see the overall estimated fetal weight. We'd also want to assess the abdominal circumference. Those are most useful in diagnosing growth restriction.
Good. If her original ultrasound had been normal, let's say estimated fetal weight at 33% with normal indices because she's 33 weeks, and the follow-up ultrasound, her estimated fetal weight was 25% and the abdominal circumference was at 8%, how would you manage that finding?
So at that point, she would meet the criteria for fetal growth restriction with the abdominal.
Yes. So now what's your evaluation going to consist of?
So at this point, it would be about 3 weeks later, you said, so she's around 36 weeks.
She's 36 weeks now, yeah.
Okay, and well, the next thing to do would be assess for the Doppler studies.
Good. Very good. Okay, so we'll add some Dopplers. Is there anything else that's important to know about on this ultrasound aside from the growth and the indices?
Well, I would want to check the fluid around the baby as well.
Yes, very good. Good. Anything else that you would, while you're reading this report, you really want to know at this point from this ultrasound?
So if there's isolated fetal growth restriction, with normal Dopplers and the fluid around the baby, there's no signs of oligohydramnios, no abnormal, nothing else that's abnormal. I believe that we could then continue the pregnancy.
That sounds perfectly fine. Is there anything else that you probably would just want to sort of check out and know from this ultrasound that you haven't mentioned so far, given the scenario that we've created?
I'm trying to think if there's something that.
That's okay. Okay. We're now assuming that she has suspected fetal growth restriction. What risk is she now at for the remainder of her pregnancy, however long it is? What are now the risks of fetal growth restriction to her?
So the risk with the fetal growth restriction, it could become worse throughout the pregnancy.
Yes, that's true. And what are the implications of that? What could happen?
So that could affect. I'm trying to think. I mean, if we're concerned for the fetus, that's part of why we would deliver her early.
Okay, good. So
iatrogenic premature.
Got it. So one of the issues here is you might want to deliver her earlier than letting her go by herself. That's important. Given that, is there anything else that you really might want to know from this ultrasound right now that you haven't told us about yet? Given that you're thinking that you might somehow in the very near future need to deliver her.
I feel like
when the examiners are asking this, remember, we always go back to the very basic stuff. What we're locked into here is we've got a fetus with a specific high-risk disorder, which is fetal growth restriction. But also, we always want to go back to and consider the very basics of our obstetrical evaluation. And if you've got someone at term, and you're thinking at some point you may need to induce her. If you decide you need to induce her at 38 weeks, what do you need to know to determine whether she's a candidate for an induction of labor?
Oh, the position of the baby.
There you go. Fetal presentation. Yeah. It's the very basic stuff. In the exam, we're walking through this because this is how exam scenarios are. We'll get tunnel vision on the fetal growth restriction, but when they keep asking, it's just back out and remember, we need to know the very basics. So, think about, I'd have to deliver at some point. When I deliver a healthy patient, what do I need to check out? I need to establish her gestational age well, and they may ask you about the criteria for that. I do need to know whether there are any contraindications to labor. The really obvious one is malpresentation. By placenta previa, you can just name a few like that. That's the basic stuff that you'll get from the ultrasound. The location of the placenta, that would be another important thing to know. Good.
Okay.
So good. So let's move back to this patient. So 36 weeks, we've decided she has fetal growth restriction. If she has normal AFI, normal Dopplers, your abdominal circumference is 8th percentile. Everything else looks good, and she's at 36 weeks. When usually would you consider delivering her?
So with normal Dopplers, I think we could wait until 38. I would have to refer because I generally have the recommendations from ACOG easily accessible, but generally 37 to 38 weeks.
Perfectly good. Actually, anywhere between 37 and 39 is perfectly okay, depending on sort of what happens, and also sort of whether you're looking at the SMFM recommendations or the ACOG recommendations. But 37, 38, 39, if nothing else turns up, that's a perfectly reasonable range, and the examiners will be perfectly fine with that. That's kind of all we need to know. Good. There's lots more we could talk about this, but they will again keep the sort of focus to maybe just like 3 to 4 minute discussion, so that would be good. Is there any other aspect of this that you would like to talk about, Christine, before we move on?
No, not particularly. I guess maybe for the midline placement, do you think that's something that they would have questions about?
I'm sorry, the what placement? Oh, over here. She had bacteremia, so she needs long-term antibiotics. She needs established safe, effective, long-term IV access, minimizing her risks of, flying sepsis and things like that. So absolutely, no question about that at all. They're probably not even going to ask you about that. The important things, though, are they want to be sure everybody remembers with pyelo in pregnancy, there is that risk of obviously prematurity from a lot of different reasons, IUGR as well. And we want to talk about that and talk about just basic surveillance, that they would commonly bring something like that up. Good, Christine, that was great. Thank you very much. Nicely done again. Let's move back over. Let's see. I think Dr. Akinwande, Dr. Wagner, and Dr. DeRusso. We'll get to you guys quickly. Let's go to Ruby first. Dr. Akinwande, I'm going to pull up your. Okay, go ahead and Ruby, if you can unmute yourself. I'm looking down here. I don't think I actually have your case list on here. I'm going to cruise down to the bottom. Yes, hi.
It should be in the. Hi, how are you? It should be in the I think, September list.
Oh, I'm sorry. I can go back. I'm going to try to hang on just a second. Hang on. There we go. Sorry, we'll drop over to September here for a moment. There we go. Yeah, thanks for directing it. All right, we're good to go. Ready. So you choose anything you would like to talk about.
Yeah, I guess we can do somewhere in office.
Sure, go to the office. Anything you're studying on office at the moment that you'd like us to take a look at?
I need to study everything.
It's okay. Let's see. Let's go. Maybe we have not been talking about recently. Let's see. STDs. We got all kinds of good stuff in here. Let's see here. Yeah, just a second here. Oh, can we do, this is a random case number 25, vulvar disease. I think we've discussed it. We discussed vulvar disease in the past week. I've not been keeping up on what the other people were doing in the past few sessions.
Okay.
Okay, we'll go with that. All right, so let's go with the 25-year-old here. So vulvar lesions. Let's say that instead, this looks like it's going to be HSV. Let's say that instead what she has is sort of white, almost leukoplakia-like lesions of the vulva, which seem to be a little bit mildly pruritic, but mostly you just found them on a routine exam. What would we be thinking of in a 25-year-old that has sort of just very focal kind of leukoplakic lesions?
White leukoplakic lesions.
Yeah. Just sort of
I mean,
to the vulva.
I would probably be thinking more condyloma.
Okay, sure. That sounds reasonable. If you believe that they were condylomata, how would you evaluate that? I'm assuming if you're concerned, they wouldn't obviously look like verrucous condyloma, but if you think it's condylomata, what underlying disease process are we thinking of here?
So infection with what is this? HPV.
HPV, good. Sure. What are the manifestations of HPV infection of the vulva? What conditions can occur?
So we already said a condyloma, like genital warts in general.
Right. Yeah. Verrucous condylomata. Yeah. What else? Does HPV disease of the vulva cause any other manifestations or conditions?
I haven't seen this, but could it potentially be malignant?
It could be. What type of malignancy of the vulva could HPV cause?
I'm not sure. I need to look that up.
If you could just name one malignancy of the vulva, what would it be? Most common malignancy of the vulva.
Oh, I am blanking.
I mean, because the reason why your oncologist does a radical vulvectomy, what cancer are we talking about?
I don't know if there's a specific name. It's vulvar cancer.
It's a vulvar carcinoma, but there are different types, right? I mean, for endometrial carcinoma, it could be endometrioid, it could be papillary serous, it could be adenosquamous. If it's a vulvar carcinoma, what type of cell line are we talking about here?
Squamous.
Squamous carcinoma of the vulva. There you go. Perfect. Mm-hmm. Are there any other types of carcinoma of the vulva that HPV could cause other than squamous carcinoma of the vulva?
Could it lead to adenocarcinoma?
Possibly. That's true too. Could it cause a melanoma of the vulva?
I mean, yes, we can definitely have melanoma of the vulva. I didn't know it was caused by HPV.
No, I'm asking you, is HPV the underlying cause of melanoma of the vulva? Or could it be?
Not that I'm aware of.
No,
I know, no, it's not.
No. So
Okay.
primarily squamous, maybe no. Good. So good. So HPV could cause vulvar condylomata, which are benign. It could cause squamous carcinoma of the vulva. Is there anything else in there that HPV disease of the vulva could cause? Anything between condylomata and squamous carcinoma of the vulva?
VAIN.
VIN. There you go. Exactly.
Yeah.
That's okay. And for all of you guys who are listening in on this, everybody I know who's not you right now, Ruby, is sort of thinking VIN. You're the one who's having to do this, and that's why it is so difficult to get the VIN. It's okay.
Right.
If you were listening to somebody else, you would have thought of VIN 3 minutes ago. So that's okay. Yeah, that's right. So it's condylomata, VIN, and then potentially progressing to carcinomas of the vulva. Good. So if you were concerned, if you were not sure if this was condyloma or something more serious, how would you evaluate?
So we take a biopsy of it.
Good. If your biopsy was returned as VIN2, how would you discuss what that meant to the patient and what treatment options might you consider?
Okay. So I would explain to the patient that this is a potentially a precancerous lesion, and we can treat it medically with can't think of names, but like is it TCA or podophyllin? I can't think of the.
Podophyllin. I think podophyllin is a potential one. Yes.
Okay.
Can't do that. Yeah, TCA is more like for condylomata. Podophyllin you can use to treat VIN. Yeah.
Yeah. Okay.
What other potential treatments might we have for VIN2?
We can also offer excision.
We could. Yes, that's true.
And then continue monitor. Like I'll bring her back 6 months and 1 year to monitor, make sure it's not returning.
Any other potential treatments aside from topical chemical treatments and excision?
Aside from medical and excision.
Yeah. Well, if these were just condylomata, what would your treatment options consist of? You'd probably use TCA or podophyllin. What else can you often do for condylomata?
You can do cryo for it. You can freeze it off.
Could you do cryotherapy for focal VIN2?
Yes.
Yes, you could. Yes. What else do we often do for condylomata when maybe if there are a bunch of them?
I don't do this, but you could do laser.
Laser, exactly.
As well.
Could we do laser ablation for focal VIN2?
Yes.
Yes, you could. Very good. They're all on the table. Now, going back though, you've seen some condylomata. You biopsied one. You have VIN2. Before you go ahead to treat this, is there any other evaluation that you would consider doing?
Well, she's 25. I hope we've done a pap smear.
Yes. Sure. Yes. As far as evaluating the vulva, is there any other evaluation that we should do if we see some lesions, they look like condyloma, we biopsy one and it's VIN2? Anything else we should do?
I mean, if it's, I can't think of anything right now. If it's not focal, you mean?
Right. Yes, exactly. Is VIN unifocal or multifocal?
Just put myself. It's focal.
It
is
can
not
be.
focal.
Can VIN commonly be multifocal?
Okay.
Can it?
I think, it can be.
Yes, absolutely. It can be. Yes. So is there any evaluation that we should do before we go ahead and just treat this one little site?
So I guess, yeah, completely evaluate. I'll maybe take her to the operating. No, you don't need to operate for that.
No, don't need to go. We can do this in the office.
Yeah. So just completely evaluate the area to assess if there are multiple lesions and.
And how might you tell whether they were suspicious for VIN rather than condylomata? Is there an office procedure you could do that could help you with that?
For each lesion?
For looking at the vulva in general, yeah. For screening the vulva.
Colposcopy.
Colposcopy.
Yeah.
you would absolutely do a colposcopy here with acetic acid, and you may identify lesions that under colposcopy may actually be more suspicious for VIN that you might want to biopsy. And the thing you want to be sure the examiners understand is you realize that VIN, unlike CIN, is really much more commonly multifocal, and that things that look like condylomata can actually be precancerous. And before you go into sort of do a one-time treatment, you do want to be sure that you don't find something else in biopsy and find out that it is VIN3, which is treated differently than VIN2, or that it is maybe microinvasive carcinoma of the vulva, in which case you are sending her to GYN oncology. So in the interest of sort of patient safety, we have to go through those steps. So when we have VIN, we do need to do a complete colposcopic evaluation of the vulva. We need to mark off any lesions. We may do additional biopsies, and then we manage based on the highest grade of what we found. So coming back real quickly to the question, and then we'll finish up. So if there's just one lesion, it's VIN2. How do you decide whether you're going to offer her an excision or whether we should do one of these very simple sort of freezing it or lasering it or topical procedures?
I think it would be dependent on the size of the lesion, and if it's something small and we think that we can do a like completely excise it in the office, like we can do we can just do that, but and also continue with medical treatment after.
Okay, sure. So when we have this on the cervix, we have names for the procedures we do. It would be a loop excision procedure or a conization of the cervix. When we're doing this on the vulva, is there a name for the diagnostic excisional procedure that we do on the vulva? And there is.
Sure. I mean, all I know is like we do punch biopsies, but that's just a biopsy.
Right, but this is right. We did a biopsy to diagnose the condyloma. Now that we're doing excisional therapy, and this is designed to. When we have something on the cervix and we have something that's precancerous, we do the leap or the cone to rule out invasion, right?
Right.
With VIN2, we are doing a procedure to rule out invasion. So there's a particular type of procedure that we do there. And that's why we call it a diagnostic excisional procedure. We're removing the lesion, but we're removing a healthy margin of normal tissue around it. Is there a name for the procedure?
I don't know if I would do this in the office. I mean, a wide local excision.
Wide local excision, which you do in the operating room. Yes, exactly. Yes, the examiners want you to bring up wide local excision of the vulva, which might incorporate more than one lesion if you had focal lesions. And if it were going to be more extensive, you refer to GYN oncology. Sometimes these end up being partial, simple vulvectomies, depending on the areas involved. But that's exactly it. You need to have margins of tissue. You'd have depth of excision so that you've completely ruled out invasion. That's true. As essential of VIN3, and the only way you can treat VIN3. For VIN2, it's an option depending on your judgment and discussion with the patient.
Right.
Good. Very good, Ruby. Thank you for doing that with us. Just take a minute. Is there anything about this that you'd like to ask about? Just anything we didn't cover, or sort of questions about anything that we just went through?
No, I think I need to go read VIN.
I think we covered everything about VIN that you would have to tell the examiners for the exam. So
yes.
To go and study, you're set up. If you just reinforce what we talked about, that's basically what they would ask you about. So I think we covered all the bases. Good work. Thank you again, Ruby. Thanks very much. Let's go to Dr. Wagner. Ruth, I'm going to get to you in just a second. Just run out. Let's see. I have to go back to October case list just for a moment. There we go. Dr. Wagner. Sorry.
Yeah.
I'm reversing.
Yeah, it would be under Claros.
Yeah, I'm sorry. I'm going to try and fix this so I can alphabetize it for just a second. There we go. All right, I'm sorry, it'd be under Claros. Got
Claros, yep.
Got it right here. Good. All right, ready to go. All right, Ruth, your choice. What would you like to look at?
I would say either OB or GYN. I guess that GYN's next since we've kind of.
Sure. We do whatever you want to. GYN if you'd like to. You told me. All right, got GYN up here. Anything you're looking at that we should check in about, or should we just pick something at random?
Just something at random. It's fine.
Sounds good. Okay. Let's see. Let's go down. Try and find a completely different topic here. Right, let's see when I talk about that. Let's see. Hang on just a second, so I see all the stuff that we've got here. Oh, can we do adnexal masses? Is that something? Have you done that in the past several days this week in the webinars?
I want to say I don't think so.
Okay, all right, we'll do a little bit of that. All right. Let's see. Let's do case 47 because we got an 8
Okay.
centimeter cyst there. So this is a 23-year-old. I think this is a good case for the examiners to ask you about. It's a young woman, and all you've listed here is a left ovarian cyst, 8 centimeters, but we don't necessarily know anything about it. Was this something that you picked up on your evaluation, or was this patient referred in from a primary provider with this already on an ultrasound or examination finding?
Yeah, so this patient had actually presented to the emergency room with acute pelvic pain, and she had an ultrasound performed in the emergency room that said that she had this ovarian cyst, or these 2 ovarian cysts.
Good. So, and then you were called to do a GYN consult in the ED?
Correct, yes. And
So,
then, sorry.
Yeah, go ahead if you want to add
Okay.
anything. Ready?
So actually, her pain for me seemed fairly acute. And so I was actually worried about intermittent torsion for this patient.
Okay.
Mhm.
So on the ultrasound then, before you see the patient, I'm assuming you're looking at the ultrasound. Can you tell me what, in addition to that the cyst is on the left and that it's 8 centimeters, what other specific information do you really want to have recorded on that ultrasound that will be important to you?
Yeah, so I mean, I just would want to see the size. Is it solid? Is it cystic? Are there any ultrasound? Is there ultrasound concerning for a possible malignancy? I mean, yeah, she is 23, so that's a lot less likely. But I would still want to make sure that there's comment on that. And then, since I was worried about the intermittent torsion, I just would want to just see, make sure that not that it rules out torsion, but that there's blood flow to the ovary. Mhm.
Yeah. Anything else that the radiologist might have reported that would be helpful for you in managing this patient?
Yeah. Let's see. I mean, I would say endometriomas have a particular appearance, like they usually are described as ground glass
Sure,
opacities.
that's true.
Mhm.
So the ultrasound report could have said suggestive of endometrioma or something like that. Given that we didn't know yet that it was an endometrioma, what other things do you want to know on the ultrasound that's sort of helpful you in forming a differential diagnosis here?
Let's see, maybe the presence of free fluid possibly, or
Good, free fluid. That's a very
yeah.
good.
Mhm.
Anything about the characterization of the cyst, about how it's described, that's important for you?
I mean, I would just go back to make sure, like, it's is it solid? Is it cystic?
Very good.
Is it septated?
Great. Good.
Any papillations or all the things that would make me concerned for malignancy.
Excellent. That sounds great. Good. So characterize that as a simple, complex, septate, bilateral, right, intramural nodules, consistent with endometrioma, consistent with cystic teratoma, features concerning for malignancy, free fluid. Perfect. That's actually great. Assuming for a minute to have a more general discussion, this wasn't sort of an acute ovarian torsion. If you identified this in the ED, and it was an 8 centimeter, let's say, sort of homogeneous cyst, and the patient was not acutely ill, how do you decide whether you should take her to the operating room now or whether you could continue to evaluate her as an outpatient without going to surgery right now?
So actually for us and at our institution, we're a fairly rural hospital. And so if it's after 3 p.m. and the patient is not acutely unstable, we're not allowed to take them back to surgery.
Okay.
And so that would be the first thing that I would decide if they're acutely unstable. The other thing would be the amount of pain that the patient is in. For this patient, she described her pain as very severe. She did have guarding. She did have a little bit of rebound tenderness, which is where my concern came from.
Okay. So it sounds like local pain or tenderness or symptoms might lead you to operate instead of observe this. What other things might lead you to recommend surgery rather than observation in a case like this?
Well, I would say the size of the cyst. If it's because I believe the cutoff is 5 centimeters. It increases your risk for torsion. If it's less than 5, I would say if I had any history on the patient, I could say, if it's a rapidly growing cyst, then I would be more prone to take them to the OR.
Good.
If it's been stable, then I would say then we can pursue conservative management.
Good. Those are, I think, good things to consider also. So if there were an 8-centimeter simple cyst and the patient was completely asymptomatic, are you saying you would take her to the operating room under those circumstances?
I would have a discussion with the patient. We would discuss risks
Okay.
and benefits of pursuing conservative management versus excision. You do not have to take them to the OR. Per what ECOG says. And so after discussing this with the patient, then we would use shared decision making to make our decision.
Okay, good. Is there any other criterion for which you would take her to the operating room? So far, you said if it was symptomatic, if you watched it and it was enlarging, if it was over a certain size, anything else?
I mean, I would say if it was torsion, if I had evidence of torsion, then yeah.
Yes, any acute underlying issue here. Yeah, if the patient was acutely symptomatic, absolutely. If you're not acutely symptomatic, is there anything else sort of on your findings on the examination or on the imaging that we haven't talked about so far for which you would recommend surgical management now rather than just serial observation?
I'm not sure. I can't think of anything.
Right. Well, when you were mentioning, you were going through the ultrasound, you said one of the things you were looking for was sort of papillations, other stuff. It sounded like you were considering maybe signs suggestive of malignancy. Was that what you were thinking there? Yeah. If you
Correct.
were
Yeah.
concerned about that, what management would you recommend?
I would pursue surgery. Yes.
Good. And the examiner say, what operation would you do in that circumstance if you're concerned about a malignancy of the ovary?
Yeah, so actually, so we do not have GYN oncology at our hospital. And so then I would counsel the patient that, depending on how concerned I was, I would counsel the patient about transferring her to our main hospital that does have GYN oncology for them to do her surgery versus staying at the hospital and then pursuing possibly a diagnostic laparoscopy with just a thorough exam of the pelvis, maybe some pelvic washings.
Very good.
And just lots of pictures.
No, that's excellent. That's exactly, I think the examiners would be very, very happy with that. So we recognize that if we have concerns for malignancy, this needs to be evaluated by someone who could do a staging procedure and could manage cancer. And that's not you or I at all, given our training. So what we could do is refer her out. And if not, you're exactly right. We do the things that are within our scope of privileges without sort of complicating the situation, which is, I think, a diagnostic laparoscopy is very well said. Gather as much information as you can about the mass, pictures, washings, if you actually can take a little biopsy at the surface, if you want to try that, without rupturing it, that's fine. Looking around for any other signs in the pelvis, collecting that information, and then reviewing it with GYN oncology. That's absolutely right. And I think doing more than that is not something that we should be doing in a case of suspected malignancy. Perfect. That was very nicely said. Good. Ruth, that was great. Thank you. Let's and we can carry on. Anything else you'd like to talk about that? That was actually a really nice rundown of kind of how to approach in general a significant size adnexal mass.
Yeah. I mean, I guess my only question about this, since she was 23 and she didn't have torsion actually. I really couldn't explain why she became or had acute pelvic pain in the setting of this really large cyst, which I don't think had grown rapidly since it was an endometrioma. But I mean, the cystectomies are still, I think was a real good thing to do.
No, absolutely appropriate. And then now that you've identified she has, fairly advanced stage endometriosis, what will your, more long-term ongoing management will be? This will be sort of multi-factor management, probably. Good.
Okay.
Good. Nicely done. Good job. Thank you, Ruth. That was another really good discussion. Let's cruise back here. Let's see, Dr. DeRusso, good, Stephanie, and then we'll get up to Dr. Chatterton and Dr. Musa. Hang on, Stephanie, I'm going to grab your cases for a moment. I think it should be right in here. Open. Oh, there you are. Good. Alrighty, Stephanie, already. What would you like to look at?
Anything is fine.
Okay, let's see. Let's see. Could we haven't hit OB, I think, in our second go around. Could we do an OB case?
Yes.
Okay, we'll go with that. Anything you're looking at on your OB case list that you'd like us to touch on? Other than just
Not yet. Anything is okay today.
okay, that's fine. Let's see. Let me take a look here. Let's see. Oh, let's see. Can we look at case number 24? Again, just sort of picking kind of at random. So there's a bunch of things going on here with this patient who's 26 and she's in her second pregnancy, and she did actually get to a full term, had a nice delivery. You've mentioned here fetal macrosomia. Could you tell me very briefly what findings in this patient led you to put fetal macrosomia as an antepartum diagnosis in this patient?
I'm trying to remember why she was having the fetal surveillance.
Okay.
I know.
Okay, well,
I think.
Yeah, regardless of why she was, maybe it was just for the hydramnios. What findings led you to put macrosomia here on the left-hand side of the case list?
I think it just was something we knew going into her anticipated delivery. Actually, I'm pretty sure she was seeing maternal fetal medicine for the polyhydramnios, and that is why she ended up with the induction a little bit early, which I know you can go to 39, but I think it was a decision made with the specialist. But the fetal macrosomia would be a consideration in the mode of delivery. If we knew that she had diabetes, we would recommend a primary C-section, or at least consider that strongly if the estimated fetal weight was 5,000 grams. Outside of a gestational diabetes, if the estimated fetal weight was 40, oh, I'm sorry, I said it backwards. With diabetes, 4,500 grams, without diabetes, 5,000 grams. You could offer a primary cesarean section. She had had a prior vaginal delivery, and with that, I think her estimated fetal weight was somewhere around 4,000 grams by ultrasound. And so we just, I counseled the patient that it was reasonable to offer induction and attempt at vaginal delivery.
Okay. When in a patient who had, so did she have a documented macrosomia at this point?
She did.
Well, how
okay, yes, go ahead.
Now, how did you document then? What criteria did she meet that told her that this was definitely a macrosomic infant before we?
It was the abdominal circumference, I think in her case, was greater than the 95th percentile, and I can't remember if the total estimated fetal weight was greater than 90th.
Okay.
It may happen.
Okay. Is that is that the definition of fetal macrosomia?
Mm-hmm. I don't actually know at this moment.
Okay. The reason I wanted to pick up this case is that on the left-hand side, we have to talk about this as suspected macrosomia because we can't actually tell for sure on the ultrasound.
Yes,
so if you had an estimated fetal weight of 4,000 grams and an abdominal circumference that it was above the 95th percentile, what is the standard error of measurement on this, late pregnancy ultrasound regarding the estimated fetal weight in the abdominal circumference?
So it can be around 15% or so plus or minus almost a pound at full term.
Exactly. If the examiner said, so did you document that this patient clearly had macrosomia? What would be your answer?
If I did, it was incorrect. Suspected macrosomia.
But if the examiner said, did you document then prior to delivery that this patient had macrosomia? How would you answer that question? Yes or no? Were you able to establish a clear diagnosis of macrosomia in this patient prior to delivery or not?
No.
Good. That's perfectly fine. Good. So when you discuss this case, and if they bring it up, the first thing you'll say is, now, before we discuss this case, I would like to just correct something. I've listed this patient as fetal macrosomia. Clearly, given the information on this case, I could not identify that prior to delivery. What I meant was it is suspected fetal macrosomia.
Okay.
And as soon as you say that, we're fine. And now we're talking about, what the examiners expected this case really would be. So the next question is then, what was the indication for her delivery at 38 weeks gestation?
So I think she was seen in consultation with maternal fetal medicine. And
yes.
While I know that suspected fetal macrosomia is not an indication for early induction, I believe that combined with her polyhydramnios and perhaps just difficulty with her compliance with prenatal care. I think she had some history of missed visits. I think just kind of individualizing her care, shared decision making with the patient, offering an induction at that point was felt to be reasonable.
Okay, was felt to be reasonable according to whom?
Well, we co-manage these patients with our maternal fetal medicine specialists, and so their recommendation had been in the patient's chart, and I didn't have compelling reason to contradict that.
That's fine. So the clear thing you want to say is MFM made that recommendation and decision.
Okay.
If the examiner, so if you had no MFM and you just managed this patient by yourself, would you have planned to deliver her given this information at 38 weeks gestation?
No, I typically would plan a 39-week
exactly
delivery for this patient.
And that's all you have to say, and you're fine. There's the issue here. MFM recommended it, and the question is, is that to your understanding the standard, ACOG national recommendation? It's for suspected macrosomia. It's not. We don't have a medical indication for delivering prior to 39 weeks unless there's some other complication related to fetal testing or maternal status or something like that. And I just wanted to bring this up because these are the two things that sort of make this case something the examiner should pick up. First of all, the issue of, did you have a diagnosis of fetal macrosomia? You didn't, but that's okay. You call it suspected macrosomia, which is what I think you really meant to say. And the other thing is there anywhere in this case an indication for delivery at 38 weeks according to ACOG recognized criteria, which is what your examiners want to know? The answer is no, there's not. But that's okay because you did not make the decision to deliver this patient. This is on the MFM people. And in the exam, you'll make it very clear that that was their recommendation. And according to your department protocol, you're expected to follow that. But your understanding is that in general, the strict interpretation would be she would not be delivered until 39 weeks. Okay. And you tell them that very specifically. And this is one of the things about many of us are in situations where other people are making decisions for us, and the case ends up on our case list, but it doesn't meet the criteria that we would want to defend in an exam. So we don't want to defend things that are not defensible. Okay. And in this case, you back off and you discuss it. Right. So very briefly, just maybe last question. So this is suspected fetal macrosomia. Why was it important for you to put that on the case list? What are your concerns for a patient at full term who may have fetal macrosomia? What are the potential risks or implications?
So knowing that we are expecting a baby on the larger side, we can just make some delivery preparations. So anticipate a possible shoulder dystocia. So have extra staff ready if possible. Also higher concern for a potential postpartum hemorrhage. So make preparations in advance for that.
Oh, good. Any other things that could complicate a delivery in a patient who has fetal macrosomia? Those are two really good things. Basically, is she at higher risk of, for any reason, requiring a cesarean delivery during this labor?
Yes, her risk of labor dystocia is higher.
Exactly. Yes, that's true. So she's at increased risk of cesarean delivery, interpartum or postpartum hemorrhage, shoulder dystocia. Very good. Any other potential implications or risks to this delivery if and truly we have a macrosomic fetus here? And now we're just going to think sort of more broadly and generally. Do macrosomic infants tend to have any neonatal issues?
Yes, so they have a higher likelihood of hypoglycemia or hypothermia and need for further resuscitation.
Very good. Good. So would you counsel this patient about the option if she were interested in delivering rather than cesarean rather than vaginal delivery, given how you presented this case?
I would, I'm sorry, if she asked about a C-section or if I think
when you're talking with her about the implications of macrosomia, shoulder dystocia, other stuff like that, would you counsel her that there is an option if she elects it to deliver by cesarean rather than vaginal delivery, even in the absence of a medical indication?
I would probably mention it, but then try to explain to the patient that the overall occurrence of these risks is very small. She's already had a baby vaginally, so she has a proven pelvis up to, I can't remember her prior weight, but so yes, I I could discuss it with the patient if she was very concerned about one of these things, but also just try to alleviate her concerns by discussing the actual small percentile of cases that have these complications.
Good, excellent answer on a few points here. First of all, we are actually obligated to let the patient know that there is such a thing as maternal cesarean delivery electively on maternal request. If we discuss these issues and something that the patient hears about shoulder dystocia or something that she knows somebody has had really makes her very anxious about a labor and delivery, she may have an elective, it would be an elective cesarean, but she may, but you're absolutely right then that you would counsel her sort of in the realistically about the potential risks of this and about vaginal delivery versus cesarean. And the other thing that you very nicely slipped in there is that you're individualizing this patient's care. You're actually considering that she's had a previous pregnancy and sort of what was the delivery weight of that baby and the gestational age of that baby. And how does that help you to interpret sort of where she might be at this point in her pregnancy? And that's all information that shows that you're really thinking carefully about the patient. You're describing it very nicely to the examiners. That was very, very nicely presented. And that would be a solid defense, I think, in the exam. So the important thing again about this though, or do be sure to discuss this as suspected fetal macrosomia and be able to sort of know that if you can go back and get it, the details of that patient's weight in the industry and how you discuss her. The issue about sort of that we can't really you can't defend this 38-week delivery on the basis of what's on the case list, but that was somebody else's recommendation and your limitations and sort of how you have to handle her. And if you were managing her solo without MFM, how would you have managed her? And you gave exactly the correct answer and really nice counseling for that. That was very nicely done.
Thank you.
Good work. Thank you. Once again, really good. We've only got several minutes. I'd like to get one more of our candidates up if we could. I think there was Dr. Chatterton was up and then Dr. Musa. I think Dr. Chatterton was up first. So I'm going to try to get to Carolyn and come to you in just a moment. Let's see if I can go to cases here for a moment. There we go. Hi, Carolyn. Can you hear us okay? Carolyn, are you there?
Yes. Can you hear me?
Hi. Okay. I missed. Yes, let's go ahead. If
Yes. Can you hear me?
minutes over, that's fine. Yeah, we're ready to go. Have your case list up here. What would you like to look at?
Can we do GYN?
Of course, yes. Anything particular on GYN that you're interested in?
Anything that you would like.
Anything at all? Okay, let's see. Well, we'll try to go to something completely novel then. Let's see. I'm gonna have to work for a minute because we've discussed a lot of stuff today so far and some really good discussions. Let's get something totally different here. Let's see here. Can we do briefly just case number 9? Just it's something we haven't touched on. So pregnancy of unknown location. In this case, I think let's start very simply. How in this case did you establish the diagnosis of pregnancy of unknown location? Can you walk us just briefly, and maybe in 30 to 60 seconds, to what did you find and what was your presentation that led you to that initial diagnosis?
Sure. So initially, the patient presented to the ER with vaginal spotting in early pregnancy. There were no ultrasound findings that established the location of the pregnancy, and she had a beta HCG below the discriminatory zone.
Oh, okay.
So based on those two things, we diagnosed her with a pregnancy of unknown location.
Got it. So she had an ultrasound that did not show an intrauterine pregnancy and did not suggest an extrauterine pregnancy. Is that correct?
Oh, you know what? I'm sorry. I'm getting her mixed up. She
Okay.
we counseled her that it was a pregnancy of unknown location, but based on the HCG value, which I'm sorry was above the discriminatory zone, it was possible it was an ectopic pregnancy. She didn't have any history of having passed any fetal tissue, and so because we weren't able to confirm that it was intrauterine, we treated her with methotrexate.
Oh, okay. So she had an HCG above the discriminatory zone and no findings at all within the uterine cavity?
Correct.
Okay.
Thickened endometrium.
Thickened endometrium. Good. Were there any findings in the adnexa that were suspicious for an extrauterine pregnancy?
There wasn't anything in particular, so that's why we didn't definitively call it.
Good. Okay. In a case like this, a pregnancy of unknown location, statistically, which would be more likely, that the pregnancy is actually inside the uterus or outside the uterus in a situation like this?
If it's above the discriminatory zone and we're not able to see anything in the uterus, then we have to have a really high suspicion for an extrauterine pregnancy.
Okay. If we were to look at the 100 women in this situation, ultrasound non-diagnostic for intrauterine or extrauterine pregnancy and HCG above the discriminatory zone, of those 100 women, how many roughly would be likely to have ectopic pregnancies? Just a very ballpark basic figure.
I do not know the number, but I would think the majority of them.
Okay. Are you aware of any recent ACOG information regarding how we should stepwise approach the evaluation of pregnancy of unknown location? And where I'm going here is the issue of should we do a uterine aspiration first to evaluate for a possible undetected early, intrauterine implantation, or should we go to methotrexate or laparoscopy next?
So you can start with, after counseling the patient, of course, you can start with trending the HCG, and that can
That's
help
true.
you kind of
Yes.
discern what direction this pregnancy is going in. If this patient in particular wanted to be aggressive and just she didn't want to take any risk, and so she, after counseling, requested to proceed with methotrexate, we could do a uterine aspiration, like you mentioned, to evaluate for any chorionic villi, which would support the diagnosis of an intrauterine pregnancy.
Good. That fleshes out the answer much more nicely as far as caseless defense. I think as an examiner, I think what would be confusion to the examiner is the story sort of got stopped very early on. The examiner was expecting to say it was above the discriminatory zone. We weren't sure, so we might have trended the HCGs more. We might have, we could have repeated the ultrasound. We might have done the uterine aspiration. The examiner would be wondering a bit about going to methotrexate, which is, it's chemotherapy. It's cytotoxic and it does have risk, before maybe getting a little bit more information. And the reason that you did it in this case, though, was after very specific counseling with the patient, shared decision making, and taking into account that the patient had very specific sort of concerns and requests for how this should be managed, which would not apply probably to every patient in your practice who is in this situation. So getting that specific information there was perfectly okay. But I think even above the discriminatory zone, trending levels would be okay. Maybe doing an aspiration. Quickly then, since you did go to methotrexate, how would you go about determining whether it was safe for this patient to receive methotrexate?
So I would evaluate for any relative or absolute contraindications.
Yes, and what are the absolute contraindications that you would want to check out?
So absolute contraindications would be if the patient is hemodynamically unstable, if she's if there's an confirmed intrauterine pregnancy.
Yes, good.
And if she has an allergy to methotrexate.
Sure.
Those are the ones I'm thinking of right now.
Anything else important?
There would be other relative contraindications, which would be any history of pulmonary disease. If the patient is non-compliant or there's a concern she won't follow up closely.
That's good.
Or, of course, if the patient refuses the treatment.
Sure. Yes, of course. Yeah. How is methotrexate in general metabolized and excreted from the body? What's the route of metabolism and excretion?
Hepatic metabolism.
Renal. It is 90% renally excreted.
Renal. Okay.
Yeah. So absolute contraindication would be any evidence of renal insufficiency. Very, very important because insufficient kidneys are very sensitive and we can actually harm somebody by that. So there is elevated liver function tests actually would be considered a contraindication. Renal insufficiency or any concern for underlying renal disease, absolute contraindication. Peptic ulcer disease, that's contraindication as well, right? Pulmonary as well. Good. So very briefly then, so once you decided that she's going to receive methotrexate, how do you follow her up then? If she's an appropriate candidate for it, she accepts it, and you give her the dose. What are you then like? Since we don't know the location of the pregnancy, how are you determining whether the methotrexate has been effective? Since there's no imaging that could help us here.
So we would follow her on day 4 and day 7 after methotrexate, and we would look for a decrease from day 4 to day 7.
Good.
In the beta HCG.
Fine. If her HCG's plateau did not change at all between day 0, day 4, and day 7, where would you go with that?
She'd be a candidate for a second dose of methotrexate.
Sure. Okay. Is there anything else that we might do before doing a second round of methotrexate?
Could also offer her a laparoscopy at that point. So
Okay.
you could counsel her for that.
Could do that too. Is there anything else you might offer her as far as a further evaluation?
I'm not sure.
Okay. Would you consider, since we haven't done it, going to the uterine aspiration? Or the
yes.
uterine sampling? Yeah, I would keep that at top of mind,
Okay.
because that really is, that's the step these days. Is that sort of
Okay.
early on? We would do that before the methotrexate if we could, but I always come back to that if we're not sure. In reality, when you were answering sort of what was the statistical likelihood of his patient having an ectopic pregnancy, I think you were thinking about this particular patient in general, but truly for pregnancy of unknown location, many more of them are in the uterus than out of the uterus. Even if we have this situation of nothing on the ultrasound and HCG that's above the discriminatory zone, statistically it is more likely to be intrauterine than extrauterine, and it is reasonable to evaluate that possibility before exposing the patient to a cytotoxic agent like methotrexate.
Okay.
So in the exam in particular, I would keep that in mind, because the examiners are going to expect us to sort of, maybe trending the HCGs a little bit more, getting more information. You could even follow up an ultrasound if you're really sort of locked into pregnancy of unknown location, probably evaluating for a possible intrauterine pregnancy before going to methotrexate. If there's a hypothetical discussion or a structured case, I would go that way.
Okay.
Good. Thank you, Caroline. That was, once again, really useful to talk about. Thank you. Is there we've got a couple minutes. We're going to go over just a little bit today. Anything otherwise that you'd like to ask about this case, since we sort of took a circuitous route on that?
From I guess after this patient ultimately came back with a ruptured ectopic, and so we took her back.
Yeah, so you nailed it in the first place. Yes, it was an ectopic.
Right. And obviously she failed the methotrexate. So are there any questions you think they could ask based on that?
Oh, yes, absolutely. So when you follow up your methotrexate, what signs do you look for, or what do you counsel the patient to report to you that might be signs that she was developing a leaking or ruptured ectopic pregnancy?
So we would look for abdominal or pelvic pain,
Yes.
Any evidence basically of hemodynamic instability, if she's having dizziness or lightheadedness, fainting, and not able to lie flat would also concern me for hemoperitoneum, things like that.
Perfect. Yeah, increase in abdominal pain, unexplained vaginal bleeding, especially lateralizing pain, back pain, nausea, vomiting, right? Lightheadedness, signs of hemodynamic instability, and all good stuff. Exactly. That's exactly what they'd ask you about. So just, what were the warning signs that led you to think that, I needed to go and take her for an emergency laparoscopy, short of her just showing up in the ER? That was perfect. That was very nicely done. Thanks.
Okay.
Good work. I didn't do a couple questions before we settle down. Dr. Otto has been hanging out here, I think. Alexander had a question. Alexander, go ahead. Did you have a question for us? Alexander, are you there? Come back to Alex in just a moment. Yeah, Dr. Arditi, Lauren, you had a question. Let me undo Lauren here for a minute. If you want to unmute yourself, Lauren, if you had a question for us, because you have the question mark raised. Anything you'd like to discuss with us, just unmute yourself. And otherwise, we'll wrap up for just a moment. Let's see. Good. Alex, are you there? Dr. Otto, are you there? I'm kidding.
Oh, I'm.
Okay. Well, I'm sorry, Alex. I just muted. Go ahead.
Can you hear me okay?
I can. Yeah, go ahead. Yeah.
Okay, perfect. I was just wondering how important it was to know the staging system for endometriosis.
If you have it on your case list, I think it's good to know. Yeah, we classically, when this first came up, we use the AFS. You can use the AAGL now. I would know the basics of it. If you have any significant endometriosis on your case list for that candidate, we had bilateral endometrioma. I would definitely talk about staging. Yeah, that's just something we should know. Yes, absolutely.
Perfect.
Thank you. Let's see. I had a couple more here. Dr. Santos, let me go back to Janelle. You had a question, I think.
Oh yeah, I was just wondering. You asked for the last case a question of what's the statistic for patients with an HCG over 3. Yeah, is there one or?
There's not, no, it's not. It's, remember ectopic pregnancies are pretty, they're one in every, couple hundred pregnancies or so, maybe. When we get into the specific situation where we've got non-trending HCG titers and we're not finding anything on an ultrasound, it actually does increase the risk of an ectopic pregnancy. But in general, it's still, the majority of these are actually intrauterine. Which is why ACOG has sort of set up this protocol as to sort of how we work through it. We can avoid giving patients methotrexate when it's unindicated if we just do those intermediate steps.
Okay, great, thanks.
Good, thanks. Let's see, Dr. Musa, Rafi, I think you had a question also. Let me get you unmuted here for a minute. Yes, go ahead.
Yes. Can I have, first of all, for lichen sclerosis, do we always have to biopsy before we start treatment?
Oh, good. So we're talking about the VIN thing. If this had been a 65-year-old patient, I think lichen sclerosis for leukoplakia would be at the top of the list. I would do an evaluation, and if you saw any suspicious features for it, you might want to do a colposcopy, although it's difficult with lichen. It's reasonable to do an initial course of clobetasol as treatment if you think it's uncomplicated lichen sclerosis. It is very important, and we always do this in our practice, to bring the patient back 4 weeks later to be sure, once we have cleared that, there are no underlying issues. And in the past year, I have actually seen 2 of our patients who we have cleared it. We have identified an underlying VIN, and one of them actually had an early squamous carcinoma. So VIN can live in there with lichen sclerosis. They're actually, the lichen does not turn into VIN, but they can coexist, and you do want to be sure that you are not unmasking it after treatment and then not looking for it. So doing the follow-up is very important because it can actually be in there. And sometimes actually what looks like lichen sclerosis will in fact be VIN. And when you treat it and it doesn't resolve and you biopsy, that's how you find that it's in the VIN category. So that's a very important consideration for the exam. You're right.
Yeah. Another question, please. Can we have Mirena IUD for antiphospholipid antibody patient?
Yeah, my understanding is yes. I always check with our hematologist, but usually things that are progesterone only in people who have APLS or who have had a DVT is okay. For the pulmonary embolism, because that's a much more aggressive sort of thrombotic process, people are on the fence about whether it's safe to use progesterones or not. I would always consult with our hematologists about that. Some of them are feeling not comfortable about that. But if they have APLS without a VTE event, or if they have a DVT, progesterone, IUDs, and progestational agents in general are okay.
Are you okay if I ask more 2 questions?
Yes, they are good. We do need to go quickly because they're going to cut us off in about 3 minutes. Yep.
Yeah, so are we allowed to give metronidazole in the first trimester for the patients?
I'm sorry, allowed to give what?
Metronidazole.
Oh, metronidazole in the first trimester, there's some question about that. If we could use something else, that would probably be a good idea. I would not have any problem, I think, using Metrogel or vaginal metronidazole. The oral metronidazole is probably okay, but there's enough question at the moment that I might try something else.
Last question. If a patient on SSRI and she had low lipido, do we change it or we add something for the treatment for lipido?
Oh, very good. So now we're talking about sexual side effects of SSRIs. In this case, if I were in the exam, I would not want to defend having to do that myself because I am not the expert on management of psychiatric disorders. I would refer her to a psychiatrist or a behavioral specialist and have them review that with her and have them determine which other medications should we be on. We're, primary care stuff like that, we're okay for identifying the signs and the symptoms, and we could sort of start a medication, but it is really best for us to have them to someone who really knows the pharmacology of that much better than we do. So the answer in that case is we would want to think about switching it to another agent to improve the sexual side effects issue, but I would prefer that someone who is a medical psychiatrist do that for me.
Okay, thank you.
Right.
Thank you.
Thank you. All right, we are going to wrap up for this evening. Thank you all for joining us. Again, this is archived, and you can come back anytime before the exam and listen to this as well. We're moving right in again tomorrow. We start our regular Sunday through Thursday. It will be case list defense again tomorrow evening with one of our faculty. Please come back and join us. Have a great rest of the day. Thank you all for meeting with us on a Saturday afternoon.